Greetings everyone. Today I'll be talking about childhood and early onset disorders. But before proceeding forward, let me introduce myself again. I'm Dr. Tiwari. I have been creating videos, especially in different medical topics, and especially again for USMLE, lab, or NCLEX students. My videos may not be for those in med school or in nursing school, but obviously if you try to prepare for competitive examinations, then this video will help you a lot. And yes, let's proceed forward. So today I'll be talking about childhood and early onset disorders, psychiatric disorders. Okay, so since it's a childhood disorders, so it generally begins in early developmental years, and these continue up to the adulthood. And yes, there will be neurodevelopmental and behavioral conditions that we'll be talking about so now, and multiple disorders we'll be talking about here. Attention deficit and hyperkinetic disorder or hyperactivity disorder, this is the first one. So whenever we say that the children has ADHD, then generally the child will either be hyperactive, that is excessive motor activity and restlessness, or he has also an inattention, that is he is often finding difficulty in focusing something or maintaining attention, and also he or she may have impulsivity, and that means they act without thinking through consequences. And now especially in USMLE, ADHD is quite easy to diagnose, and a few questions will be asked about the treatment drugs, but still when you have to make a diagnosis with ADHD, few things will be important, like this ADHD will always be onset before age 12, and but the diagnosis must be made to the children who are 4 years after 4 years, let's say 5 years and so on. So when the child is out of 4 years and he or she starts developing these features before 12 years, then we can diagnose that person has ADHD. And again, the features will be hyperactivity, impulsivity, and difficulty maintaining focus, that is inattention. And this is very important part topic, sentence again, it must be present in greater than 2 settings, not just in school, but also in school or home, or let's say church or temple. Okay, they either have normal intelligence, but yes, so their intelligence, their IQ may be good, but again they find difficulty in schools, in performance, they will have difficulty because they have inattention, but again they have normal intelligence. And the person who has ADHD, so when diagnosed early, then let's say earlier than 12 years age, this ADHD persists throughout the adulthood. I mean, it's not always, but it's often persists into adulthood. Okay, and these children, they have behavioral, cognitive, and they may have behavioral, cognitive, and other developmental disorders also. Now, one important questions from this topic is stimulants is the drug of choice here. So methylphenidate, we give this drug, and behavioral therapy, we can use behavioral therapy to the children. Atomoxetine is another drug. If the parents don't want to give stimulants, then atomoxetine can be other drug. Similarly, alpha-2 agonists like clonidine and guanfacine, these drugs are also used in the patients with ADHD. So we have to remember 4 drugs like methylphenidate, atomoxetine, clonidine, guanfacine. Okay, and behavioral therapy is obviously given. Now let's say next condition is autism spectrum disorder. This is quite common in the US especially, and also increasingly common in different parts of the world in present day children. So autism spectrum disorder, so there are wide range of presentations and severity levels. So we say is spectrum. In these patients, and there will be social deficit, that is they have difficulty in maintaining social interaction and communication. They have communication issues, and that means they cannot maintain normal verbal or non-verbal communication, and they have repetitive behaviors. That is, they have restricted interest and have ritualized patterns. That means if a child is starts playing with a toy, let's say a little plus toy, then he will just play with that toy. So that's a repetitive behavior. So clinical features in autism spectrum disorder is this onset is usually in early childhood. Social and communication deficits will be there. Restrictive interest, we have talked about this. Repetitive and visualized behaviorals. They may have intellectual disability, or sometimes some children have exceptional abilities. Okay, suppose although the child has autism spectrum disorder, but he has exceptional abilities in, let's say, playing piano. So this thing can be taken into consideration, or we have to remember these things. And also it's more common in males, and associated with it is associated with increased head or brain size. Okay, these are important things to remember. Now next is conduct disorder. So conduct disorder is it's behavioral patterns. It means the children have aggression towards people or animals, and they do something like repetitive and pervasive violation of societal norms or other rights, and they do the destruction of the property or even theft. Okay, so in USMLE we have to remember that one more thing is that conduct disorder is said to be in children, but if the conduct disorder is the features of conduct disorder matches to the person when he is over 18, then in that case we say is as antisocial disorder, personality disorder, not the conduct disorder. So again, conduct disorder is the such children which are let's say doing something antisocial, but again they are not 18 years old, and in that case they will be either this aggression, excessive aggression towards people, animal, they don't respect others' right, they do the destruction of property, theft, and all sorts kinds of things. Now next we'll be talking about is a disruptive mood dysregulation disorder, also DMDD. So it's like in this case the children will have severe temper outbursts. That means recurrent explosive episodes and persistent irritability. So they will develop constant anger, outburst, and then reactions often exceed the situational severity. So yes, often we feel we have variations in our mood, but in this case with the children with disruptive mood dysregulation disorder, their anger is almost exceeds the situational severity. That means it's unjustified. Okay, so clinical features again is onset must be before age 10 and diagnosis is after age 6. So and in this case the children will have severe recurrent temper outbursts, severe anger outbursts. Okay, and yeah, treatment must be cognitive behavioral therapy. Sometimes we give stimulants. Okay, and antipsychotic stimulants was also given in case of ADHD, and we may have to prescribe them antipsychotics also. Now next is intellectual disability. Okay, so intellectual disability is like we have to talk in, okay, and in this as I said, in intellectual disability the people will have global cognitive deficits as well as impaired adaptive functioning. So what does this mean is that when you see the children has global cognitive deficit, that means his or her reasoning power, memory, abstract thinking, judgment, language, learning, all of these things are affected. Okay, so that's a global cognitive deficit, not one but all of these sectors like reasoning, memory, abstract thinking, judgment, all of them are affected. So that's global cognitive deficits. And also with the people with intellectual disability, they will find difficulty with education, with employment, with communication, and as a result they are not independent. They cannot be independent quite easily like other people. So clinical features again, global cognitive deficits, and since we said that the children will have difficulty with every avenues like reasoning, memory, abstract thinking, so it's global. Otherwise, if there was a problem with something specific, then we'll go with specific learning disorders. Like if he or she has difficulty reading, difficulty writing, then we'll go with the specific. But since here it's global, so we are going with intellectual disability. And as I said, the person will have difficulty in gaining independence in life. So the treatment is psychotherapy, occupational therapy, and he or she may need specific or special education. Now next is intermittent explosive disorder, let's say IED. So in this condition, the children will have sudden outburst, sudden outburst that's like a recurrent verbal or physical aggression. So, and the duration will be very short, brief duration, let's say less than 30 minutes. And after 30 minutes, the children will have immediate relief. So, and then later he or she will have regret or remorse. So this is intermittent explosive disorder. So normally he or she is good, but suddenly something triggers, and then he or she will have sudden outbursts of both verbal or physical or either aggression, and then that remains for less than 30 minutes. And that's after that they calm down, and when they calm down they will also have remorse. And so this is intermittent explosive disorder. So clinical features, again, the onset is after age 6, not before 6 but after 6. And as we have talked about all these things before. So because of intermittent explosive disorder, that he or she may develop legal, financial, or social consequences in their life. So treatment is again psychotherapy, or sometimes we prescribe SSRIs for this case. Next is oppositional defiant disorder. Okay, in this case the children will have angry or irritable mood, again, and argumentative behavior. That means especially towards the authority figures. If there is someone, let's say a principal, father, or elder siblings, and they will have those argumentative behavioral, and they do not like to follow the orders or the normal norms or the normal discipline nature. So and yes, they have spiteful or retaliatory reactions. So clinical features, again, in oppositional defiant disorder, we can say that pattern has to last for greater than 6 months, and the children will have angry or irritable mood, especially with the authority figures. Okay, and he or she will be argumentative and has vindictive behavior. Treatment is cognitive behavioral therapy as psychotherapy. Okay, so in oppositional defiant disorders, just remember that he or she will try to be defiant towards the authority figures. Someone who is more respectable, who is more senior to them, they just try to be oppositional to them. They just try to be argumentative with them. And while argumentative, they will definitely be angry, will have irritable mood, okay, and have vindictive behavior. And the diagnosis, this whole thing lasts for greater than 6 months. Treatment is cognitive behavioral therapy. Selective mutism, in this case the onset is before age 5. Okay, when before the age of 5, and the children will have selective mutism. And again, here in this case, that he or she will not be able to speak in certain situations, but when that situation evades or goes away, then they will have normal speech in comfortable environments. They have normal language development. But because they cannot speak in the specific situations, that may affect their social or academic or occupational tasks. And often selective mutism is associated with social anxiety disorder. And yes, selective mutism, to be diagnosed this case, we have the child will have these symptoms for greater than 1 month. And again, as we said earlier, the onset is often before age 5. So the specific scenarios are like the silent at school. The children will not be able to communicate or talk in specific periods or specific class in school. he or she will have normal space in comfortable environments at home or with his friends, but not in specific situations in school, let's say. And yeah, exists with social anxiety disorder. Next is separation anxiety disorder. In this condition, the child it's for the first thing is that in separation anxiety disorder is normal up to age 3 or 4. So the children up to age 4, they will have separation anxiety disorder when they will be away from their parents. But after 4 years, if the poor children continuously develops this anxiety when they are separated from their parents or their closed ones for greater than 4 weeks, then we can say that is separation anxiety disorder. And yes, in these conditions, the children will also complain about the somatic features, like they will say, "I have headache," whenever they are away from their parents, and they don't like to go to the school. So they will try to avoid the school. Okay. Treatment is again cognitive behavioral therapy, play therapy, and family therapy. Next is specific learning disorder. So we talked about this a little above, but now talking about specific learning disorder, its onset is usually during the school age years. Okay, so whenever the children is in school, then obviously that's the place where they learn, and it's diagnosed there when the children will find difficulty in learning. So they will have inability to acquire or use information in a specific subject. Let's say they have difficulty with maths, they have difficulty with writings, and despite teaching, despite intervention, if this condition persists greater than 6 months, then we call it a specific learning disorder. But again, they have normal intelligence and general functioning. Only in this specific task, or let's say subject, they will have the problem. Okay, like as said earlier, they may have difficulty acquiring reading skill despite intervention for greater than 6 months. Then we say it, okay, he has reading disorder. So again, some may have math disorder. They will have a difficulty in solving mathematics problem, or may have difficulty in writings. Okay, so in this case, we require academic support, counseling, and extracurricular activities. Next is Tourette syndrome. Children will have motor tics. Motor tics is like a sudden, recurrent, non-rhythmic movement like facial grimacing and shoulder shrugging. So some children will like this and shoulder shrugging. So that's motor tics. And vocal tics like involuntary vocalization and sound. So they'll make this sort of sound, and this has to last for greater than 1 year. So then we say it, okay, he or she may have Tourette syndrome. So let's say onset must be before age 18. For Tourette syndrome, onset must be before age 18, and they will have sudden, recurrent, non-rhythmic motor and vocal tics. Okay. They have non-rhythmic motor and vocal tics. Motor is body movement, facial grimacing, and vocal tics is like producing sounds. And this process for greater than 1 year, this has to be remembered. And they may have coprolalia. Okay, and Tourette syndrome is associated with OCD and ADHD. So often in USMLE, when they frame the scenario, they will say that the person has OCD and also has this non-rhythmic motor and vocal tics. So then you think about the Tourette syndrome, and this will be persistent for greater than 1 year. Then you think about the Tourette syndrome. So in this case, psychoeducation, behavioral therapy, and in severe cases, you use antipsychotics, tetrabenazine, and alpha-2 agonist. So these three drugs are used. Okay, you have to remember antipsychotic is also used, tetrabenazine is also used, and alpha-2 agonist can also be used. Okay, so we talked about different childhood psychiatric disorders in this video. Okay, from USMLE point of view, age of onset is important to know. Comorbidity is important to know. Like I said, here Tourette syndrome is correlated with OCD, right? So these things must be known. And yeah, pharmacotherapy, like if he has ADHD, then if stimulants is used, so those things has to be remembered, and behavioral treatment is also need to be learned. Okay. Yeah. And often in these all childhood disorders, behavioral therapy is foundational, and medications as indicated. If necessary, then only we provide the medications. Okay, with this we complete childhood psychiatric disorder. I hope with this knowledge, now if you try to solve problems in USMLE step 1 or step 2, you will be able to solve most of the problems after watching these videos. And NBMEs, you can do them. You can solve them. Also for nursing, you will get most of the holistic clinical knowledge from this video, and some for nursing specific questions and you may have to look at Saunders' book. And I hope that this video is also essential for lab students, and from next videos I'll try to incorporate some more USMLE type of questions in my videos. Thank you for watching this, and please don't forget to like, share and subscribe. See you in next video.